area or the under the foot, and you talk about superficial and deep fascia, people will say that something is not connecting. Even people who do orbital scans, we do them through across the eyelid. You don't expect to see the superficial and deep fascia. So contents, it has subcutaneous vessels, nerves, and the occasional superficial muscles like platysma. Ultrasound appearance determined by adipose tissue content. Adipose tissue is hyperechoic, supporting stroma thin, hyperechoic linear bands. To the best of my knowledge, everywhere in the body, fat is relatively hyperechoic compared to skeletal muscle. Why I tell you ultrasound imaging is challenging. When you come to the breast, fat is hyperechoic to all breast structures. And now that takes us back to the physics, which I talked about, the APP. Why should we know that fat, which we have generally known to be hyperechoic relative to muscle, in the breast it looks hyperechoic? That informs us that there are things we are talking about, that a structure is hyperechoic or hyper is relative to where you are scanning. They are comparative terms. You cannot do that like for CT, where they use Hounsfield units and they give them the actual density of that structure. In ultrasound, it is subjective. So ultrasound appearance is determined by the adipose tissue content. Under the skin, we have a lot of fat. One day I could not believe what I saw. They called everyone for theater radiograph and everyone was dodging. So the principal radiographer found me in the corridor and told me, the theater people are complaining, we don't have anyone there. Can you go and work with them? When I reached there, they were fixing a fracture of a 16-year-old female. I found they had already opened, and I looked at the skin layer, the fat layer here, and I was not reluctant to ask. I said, do humans resemble pigs? And the surgeon told me, this lady is experiencing secondary characteristics. There is a lot of fat deposition in this area to give them the curves that attract the opposite sex that this person is ready for continuing of the generation. So they told me that is a normal thing. Old women do not have that, it is eaten away. So the deep fascia, this location, dense fibrous membrane investing in muscle and deeper structures. Lucky enough, recently I had gone to the anatomy skills lab with the current cohort doing vascular ultrasound. We decided to apply the APP. We went to the cadaver room and the anatomist showed us this deep fascia, how it wraps the whole leg from here. He cut open and we saw, and I really enjoyed it. Now when I'm scanning, I actually see what I saw there. Features, it has variable thickness, thicker in exposed regions, e.g. lateral leg. Forms muscle sheath and intermuscular septa attaching to periosteum. Now everyone here is a radiographer, they know periosteum. The moment you talk about osteomyelitis, how you diagnose it is by looking at the periosteal reaction. So it thickens around the joints to form retinaculum or the fibro-osseous tunnels, maintaining tendons and nerves in place. So these are some of the importances of the deep fascia. Ultrasound appearance. Hyperechoic with an identifiable fibular pattern. Intramuscular septa seen arising from fascia are hyperechoic as hyperechoic lines. So as you can note, this is the image. This is the epidermis. And this layer you are seeing here is a layer of gel between the skin and the probe. So this is the epidermis, and from there to where the arrows are pointing, that is the superficial compartment, and this is the deep compartment. And this line separating them is the deep fascia. And in normal sense, if you go to theater and or work with surgeons, you find that this is adipose tissue. But unfortunately, if you go for cadaveric dissection, you cannot appreciate this fat layer. Ultrasound anatomy of the tendon structure and appearance. Like we've already seen, the tendons and the nerves have a similar appearance, but what will differ is the level of echogenicity. One is hyperechoic to the other. Composition and structure, tightly packed collagen fibers with intervening fibroblasts. Hierarchical bundles, primary is a subfascicle, then secondary you have a fascicle, and tertiary bundles. Connective tissue sheath, you have endotendium, loose connective tissue binding primary bundles, peritendium encloses subfascicles to form fascicles, contains blood vessels and nerves. Epitendium, teninium, thicker fibroelastic sheath surrounding the whole tendon. Like these words we've already talked about. Now this is connective tissue surrounding the tendons. Endo, peri, and epi, we already know what they are all about. We are just repeating them. So tendon structure and appearance, attachments, musculotendinous junction, sacrolemma intervenes, no direct continuity of fibers. Bone attachment, periosteum, fibrocartilage, or direct to bone. And others can insert into fascia. So for the tendons, for the muscles to do what they are supposed to do, either end of that muscle has a musculotendinous junction which connects to bone or cartilage, and the other side does the same to give it the pull you want to achieve. Morphology and surrounding structures, cross-sectional, round. The tendon for biceps muscle is round in shape. It appears like a cord or a rope. Oval in shape, this is the Achilles muscle, which is formed by 3 muscles, the gastrocnemius median lateral head, the soleus, and the plantaris. They are sheaths fused to form that tendon. In the Rwanda genocide of 93? 94. People were calling the other tribe cockroaches, and they said, deal with your cockroach. They were causing severe pain. Someone comes with a pang and he cuts the Achilles tendon. No matter how strong you are, you cannot walk. All you can do is to crawl on the ground like a cockroach. So they know they do that. Even after 2 days, they come, you will not have reached Nakuru town, and they finish you off. So Achilles tendon is a very strong tendon, named after the god, the Greek god Achilles. The surrounding sheath types. This tendon is also surrounded by a sheath. In ultrasound, we usually call it a tenosheath. But when it comes to Achilles, the name changes to paratenon. So this only comes for Achilles. But the rest, they have a synovial sheath called a tenosheath. So in high friction areas, 2 layers of synovial fluid for smooth gliding. Like this area here, you must see a sheath because your hand keeps doing this. And these ones of the leg, as you keep dorsiflexion and extension. Like we said, the only difference is paratenon, which is for the Achilles tendon. So ultrasound appearance, longitudinal plane, denser linear hyperechoic bands forming a fibular pattern. The fibular pattern we can talk about is like a lady with long hair. You pick a few of them and pull them, they form like that rope-like thing. Each hair strand, each hair fiber contributes to that whole thing you've made, which looks like a rope. So even that's how tendons look like. Transverse plane, they are hyperechoic with multiple hyperechoic foci or dots. Source of echogenicity is due to specular reflection at the interface between fascicles and peritendium. Other features, normal tendons are not compressible. All of us eat meat, and sometimes
Welcome to RadMed, your 360 degrees radiology and healthcare partner. Shop for all your radiology needs, from X-ray machines to ultrasound machines, we have it all. At RadMed, we are dedicated to revolutionizing healthcare. We are experts in radiology and healthcare equipments, serving all areas in Kenya. Why should you choose RadMed? Firstly, we provide high quality and reliable modern technology hospital equipments. Secondly, we provide personalized support for every client. Thirdly, we have a proven track record in successful installations. Globe Care Hospital in Eastleigh, we delivered and installed an X-ray machine. Lydia Key Memorial Hospital, we delivered and installed an X-ray machine and a computed radiography machine. In Calvary Hill Hospital, we delivered and installed an X-ray machine with a CR. In Ziwa Hospital, we delivered and installed an X-ray machine with a complete CR. In Mwanzawetu Health Services, we delivered and installed a colour Doppler machine with 2 probes. Brooks and Cherith Hospital, we delivered and installed an X-ray machine with a CR. In Nanyuki Hospital, we delivered and installed an X-ray machine. Esobi Healthcare. Malkia Wings Hospital. Zenit Care Hospital. Nelly Nursing Home. Pro Care Cottage Hospital. Esther, a radiology entrepreneur. Itak Hospital. Peter, a radiology entrepreneur. Mugamo Medical Centre. Jabs Medical Centre. Why should you choose RadNet? Firstly, we provide high quality and reliable modern technology hospital equipments. Secondly, we provide personalised support for every client. Thirdly, we have a proven track record in successful installations. Welcome to RadMed, your 360 degrees radiology and healthcare partner. Shop for all your radiology needs, from X-ray machines to ultrasound machines, we have it all. At RadMed, we are dedicated to revolutionising healthcare. We are experts in radiology and healthcare equipments, serving all areas in Kenya. Why should you choose RadNet? Firstly, we provide high quality and reliable modern technology hospital equipments. Secondly, we provide personalised support for every client. Thirdly, we have a proven track record in successful installations. Globe Care Hospital in Eastleigh, we delivered and installed an X-ray machine. Lydia Key Memorial Hospital, we delivered and installed an X-ray machine and a computed radiography machine. In Calvary Hill Hospital, we delivered and installed an X-ray machine with a CR. In Ziwa Hospital, we delivered and installed an X-ray machine with a complete CR. In Mwanzawetu Health Services, we delivered and installed a colour Doppler machine with 2 probes. Brooks and Cherith Hospital, we delivered and installed an X-ray machine with a CR. In Nanyuki Hospital, we delivered and installed an X-ray machine. Esobi Healthcare. Malkia Wings Hospital. Zenit Care Hospital. Nelly Nursing Home. Pro Care Cottage Hospital. Esther, a radiology entrepreneur. Itak Hospital. Peter, a radiology entrepreneur. Mugamo Medical Centre. Jabs Medical Centre. Why should you choose RadNet? Firstly, we provide high quality and reliable modern technology hospital equipments. Secondly, we provide personalised support for every client. Thirdly, we have a proven track record in successful installations. Welcome to RadMed, your 360 degrees radiology and healthcare partner. Shop for all your radiology needs, from X-ray machines to ultrasound machines, we have it all.
Footprints and smaller footprints, and allow better manipulation along the ligaments path. Recently, Mete has installed a machine with a hockey stick probe of a frequency up to 30. For the first time, when I was teaching students other things, I interested myself in looking at the annular pulse system, and now things made sense. Because I was using the wrong tools, the probes I was using were 5 to 10 megahertz to examine the annular pulse system. We have a system here which helps us to do this, called the annular pulse system. Because you remember we talked about the tendons. The longest ones come from before the wrist and continue to do this. And you have the brevis. Longest means long and brevis means short. And in clinical anatomy, you will always find that the longest do the crude movement and the brevis do the fine movements. The longest will help us pull these fingers like this, but it is the brevis which gives us the how to hold and write. They do the fine tuning. So ligaments appear hyperechoic linear structures similar to tendons, but are best assessed with dynamic positioning, stretching, and high frequency transducers to optimize their visualization. One of my lecturers is a stubborn man. He's a radiologist. He doesn't want to do ultrasound much. One day he worked on a patient, MRI, and they were suspecting a ligament tear. And he said, no, go to the other imaging center, tell them you want Mutesasira, and I've given him the instructions here on what to do. Tell him to call me when he has finished. And when he was teaching, I used to give him a hard time. I was telling him, you see, I came here to do a master's in ultrasound, not in MRI or CT. And he kept insisting, no, as you project the ultrasound, there must be an MRI image besides. All I need is to understand the anatomical relations here, not to tell me the disease. He told me it would be embarrassing. A patient coming from an MRI, he takes the report to the doctor or a physician, they know nothing about imaging, and they call you in to show them what this report is talking about, and you cannot even point where the pathology is. He told me, that's when you will see that you need this. And like in Uganda, we say a few moments later, there was a doctor who always liked asking for MRI. Like I told you that it's terminology, it's a language. She usually called me, what do they mean by this here? Okay, show it to me on this. You get what I mean? And that's when I realized that the man's advice was very important. So you cannot do this in isolation. Always compare with other imaging modalities. And now this is an image of the distal tibiofibular joint, and that is the talofibular ligament. The bone here, the big one, is the tibia, and this one is the fibula. And this one usually is prone to tears. Many times when we walk, you step on uneven ground and you end up doing your foot like this. And the tendon you are affecting is that. Actually, a study said doctors in German, orthopedic ones, were becoming redundant, no work. And they went and they connived with shoe companies to make high heels. And now they started getting patients. So high heels put them on at your own risk. Actually, one of my colleagues that time wanted to do a study on the appearance of the Achilles tendon among people who put on high heels. And actually, I believe he would have got results because by virtue of putting on shoes, this upper part of the shoe, there is a way it locks on the Achilles. I think it must have that effect seen with ultrasound, even for us men. But now for the ladies, it becomes worse because you are also elevating it, putting it on stress. It is stretched full time, which means it is overworked. And ladies who put on heels develop thick gastrocnemius muscles because they are always what? Flexed or contracted. So ultrasound appearance of peripheral nerves. Peripheral nerves are these nerves which we can see with ultrasound, like the sciatic nerve, the ulnar nerve, the radial nerve, median nerve. So fascicular organization, nerve fibers grouped into fascicles. This one we've already seen on the other previous image where we showed the perineurium, endomeurium, and the epineurium. So you just remember that image, and this is where we are. These are the layers: endoneurium, perineurium, and epineurium. So, and there is a common saying in MSK, abbreviated as VAN, vein, artery, nerve. A nerve is always adjacent to the artery. So if you are looking for a nerve and you can't see, look for an artery in that area. The nerve is always adjacent to the artery, and that is in the deep now, in the deep compartment. That is in the deep compartment. Now you see the importance of knowing superficial and the deep compartments, which are separated by the deep fascia. The knowledge you get from there helps you to build on and get to other places. So ultrasound anatomy, peripheral nerves, longitudinal axis, fascicular pattern. This one has no difference between it and fibular pattern, but only when you come to nerves, you call it fascicular. Unilateral, uninterrupted hypoechoic band is fasciculi, with intervening linear interrupted hypoechoic bands, the interfascicular epineurium. Epineurium is the outer, may blend with the perineural fat. These nerves are surrounded by a layer of fat to protect them from damage or injury. It works as a pad. So, ultrasound appearance, this is the transverse axis, a honeycomb appearance, multiple hypoechoic dots, fasciculi of varying size, in a hypoechoic background. That is due to the supporting tissues, the epineurium, perineurium, and the endomeurium. So factors affecting resolution. And when I talk about resolution, in ultrasound we have generally 3 types of resolution. We have axial, which is totally dependent on the probe frequency. Then we have lateral. This one we have control over by adjusting the focus, and the temporal, which you also have control over by reducing by increasing the frame rate. And the more focal points you put, the lesser the frame rates you are going to have, which affects the temporal resolution. And in MSK we usually use at least a dual focus most of the times. So in narrow passages, fibro-osseous tunnels, nerves may appear more uniform. and the hypoechoic fascicles tightly packed less than intervening connective tissue. So now this is an illustration of what we did already, the nerve. You have the epineurium, the interfascicular epineurium, the fascicles which are inside. These are the ones you see. In the transverse, you see they will look like a honeycomb. And this is even the way ultrasound will depict it. So this is an image of a nerve longitudinally. This is the transverse, and that is the 3D. These are the newer applications of ultrasound, the 3D imaging. This is the nerve. So peripheral nerve longitudinal ultrasound of the medial nerve in the distal arm. This is an error. This is median nerve, not medial. Corresponding transverse image demonstrating the hypoechoic fascicular arrows and the supporting interfascicular epineurium. Canal is an area around the wrist here. It's where we see the ulnar nerve. So we are going to talk about the differences between peripheral nerves, differentiating nerve from the tendon. So usually when I'm teaching students, I tell them, when I tell them to do comparison, always do a table. It's better than writing words. You just write the parameter you are using, and you compare and contrast. You remember those questions of compare and contrast, ngoni migration and lower migration. And I told the students that when you are young, you were just funny. If they asked that question and you use Ngoni and you mislabel it as Ngoni, they will mark it correct. The same side that you ask Luo and the lower migration and you put Ngoni, and they mark it right because they are totally similar. But when you are young, you cannot discern that these things are what? You want to cram this one, then you come and cram this one. So here this is the same thing. Feature or a parameter we are going to use for comparison. You have the pattern. This is fascicular, interrupted bands. This is fibular, continuous bands. But you remember we said it's just the language. The appearance is the same as you've seen on the images. Now it's the anatomy to tell you where you are. Anisotrophy, nerves are less prone because if a nerve rarely passes over a bent structure, usually there is a thick layer of fat to keep it straight, not to turn. And these ones are highly prone. Compressibility, non-compressible, and even this one is non-compressible. Motion, nerves have less motion. This one is more motion with muscle contraction. Doppler, small perineural vessels may be seen. These ones are usually vascular. Nerves have nutrients like the brain itself, unlike tendons. These ones in a state of ischemia can easily die, but these ones might take days to notice the ischemia and die. Like the cruciate ligaments, and I was wondering where do they get their nutrients? they clearly absorb from the synovial fluid the oxygen demands and the other nutrient demands. They don't actually have blood vessels giving them the nutrients. So, dynamic assessment, peripheral nerve. Usually what we do with dynamic assessment, there is when you scan this ulnar nerve, when you do this, it moves away from the groove. Then you know there is a problem. That is subluxation of the nerve. Crucial in fibro-osseous tunnels to exclude subluxation or dislocation of the nerve. You can have excess tingling in these fingers. And you see why I'm telling you that the APP is the way to go. By clinical presentation of this, you can know which nerve is affected. If the tingling is affecting the little finger and half of the ring finger, then you know it is ulnar. And where the problem could be is Guyon canal but most commonly the problem is here. You might find that the nerve is completely out and it is here, not in the canal. Then you end up helping the patient. The orthopedic surgeons will pull it back and make sure they keep it inside the tunnel. So key takeaways: nerves have distinct fascicular architecture on ultrasound, hyperechoic bundles in hyperechoic background. Recognizing this pattern and differentiating nerve from tendon is essential for accurate diagnosis, particularly when assessing for entrapment or instability. Now another important structure, these are bursas. These are synovial membrane subdivisions of the bursas. There are 3 types in the body. You have the articular. That is, articulation is where 2 bones meet to form a joint. So, synovial sheath, you've seen the tendons and the bursal. These are friction reducing sacs. So let's look at the bursal types. You have the bursa mucosae and the bursa synoviae. These ones are mucus and synovial fluid. Mucus is slightly denser than synovial fluid. The synovial fluid is also denser than serous fluid. That's how the classification came about here. So locations: subcutaneous, between skin and bone prominence. The biggest example we have, which is always the cause of knee pain, and because of using the wrong probes, we keep missing it. It is the prepatellar bursa. It's within this thin layer on top of the patellar bone. Function reduces friction from superficial pressure. Example, prepatellar bursa between patella and the skin. Bursa synoviae, deep between muscle and the tendon and the bone. Reduces friction during movement, and some communicate with joints. Example is the subscapularis bursa, shoulder, and the iliopsoas bursa, hip. Iliopsoas is a tendon for the 2 muscles, the psoas and the iliacus. So let's look at anatomy of the bursa. Normal state, not usually discernible at ultrasound. when distended with fluid, anechoic fluid between the hyperechoic tissue layers, adjacent structures appear hyperechoic fat planes and capsule. So this tells you that when you see a bursa in a location where you expect it to be, and you can discern it with ultrasound, that is already an indication of a pathology called bursitis. Bursa are potential spaces lined with synovium, visible on ultrasound only when fluid distended. They appear as anechoic collections in characteristic locations. Now this underscores the APP, the anatomy, pathophysiology, and physics. Either superficial mucosae or deep synovium may communicate with adjacent joints. And fluid distension of the subacromial. There is a very big bursa here. And when you see the way it is named, you have the deltoid muscle and acromion process. So it derives its name from there, the subacromial. Sub means under and subdeltoid. So if I'm looking for it, I know it must be beneath the deltoid muscle. And the acromion is a bony landmark which we can easily see at ultrasound. So the bursa capsule arrows and the peribursal hyperechoic fat may have similar echogenicity and are difficult to separate. So here we have two structures, the bursal capsule itself and the fat adjacent to it. Since both are hyperechoic to muscle, we cannot discern which is which at ultrasound. And now this is the bicipital groove, and that is the long head of the biceps. So now let's look at ultrasound anatomy of bone. One time I happened to work on an old lady. She had a lot of pain around this region, and she was telling me I cannot even sleep on that side. She did the chest x-ray, and they told her the lung fluids appear normal, and the bone structures of the chest are also normal. But with ultrasound, I managed to see a cortical bone discontinuity, which was a fracture. And on taking clinical history, I asked her, did any sharp impact happen on that region? She took some time and then said, oh, now I remember. I was going somewhere and I knocked a tip of the table. And since she was an old lady, you know they are prone to fracturing quite easily. So provide excellent anatomical detail of the cortical surface of superficial bones. Actually, I've realized that ultrasound detects osteoarthritis before X-rays can. Some bone cortical irregularities are very minor to be detected with X-ray. And ultrasound now is overtaking X-ray because it has no radiation and can detect them earlier than plain radiography. High resolution arrows detect high resolution of the humerus, demonstrating a smooth hyperechoic line consistent with cortex margin with posterior acoustic shadowing. Here we cannot see anything beyond because there is total transmission. No sound is reflected back for the probe to create an image. And even by appearance of these muscles, you can tell which one is which, whether this was a supraspinatus or infraspinatus muscle. The supraspinatus has a bird's beak appearance, and this one looks like that. So this one, given even the bulk, the thickness, this is infraspinatus tendon. And B, fracture arrowhead at the greater trochanter with interruption of normal smooth cortical line demonstrated in this image here. You can clearly see that there is cortical bone irregularities in this area. So ultrasound of bone anatomy clinical utility, bone landmarks essential for orientation and localization of overlying soft tissue. Example is the Lister's tubercle, identifies the third extensor compartment on the dorsum. When we are doing wrist ultrasound, we have 6 compartments here, labeled from medial to lateral. We have the first compartment, second, but if you want to tell the difference between the second and the third, you use the Lister's tubercle. So it is a bone landmark that helps us. And to conclude, the lesson was about history, evolving role, technologies, and MSK ultrasound, gross, stroke zone anatomy, and all the learning materials we are structured from a textbook called Musculoskeletal Ultrasound, chapter 1, written by John O'Neill. In Africa, we tend to misquote this thing, meaning that it is what? Medical doctor. In the US, it's totally different thing. This is a doctor of medicine. This gentleman has a PhD, is a radiologist. So given the theme, we are talking about MSK in multimodality. I believe we have done that. We have talked about MSK, comparing it to plain radiography and MRI. CT usually has a lesser role when it comes to MSK. Because if you do the plain radiograph and you do the MRI, CT remains a gray zone there. You give a patient a high radiation dose for what when you can use MRI. So with that, we conclude the first part of the presentation. The next one will be about knee. I think now we can receive questions if there are any.
Vascularity. At least I saw that tendons don't have vascularity compared to the nerves.
Yes.
Do you need to use a power Doppler because of the stability? And you know, a small vascularity within the nerve to be able to look at the nerve. Thank you.
I think we shall derive your answer from this slide. By doing this motion, when you cause motion, the tendon will have movement and the nerve will not have. When you employ power Doppler, you receive vascularity in the nerve, not with the nerve. Like, and the vascular structures will also help you. You remember the vein, artery, nerve. You will always have an artery adjacent to. So the vein will also help you. A nerve is always adjacent to an artery. And really, when you get lost, these days I've gotten my colleague, the anatomist, is telling me, for whatever you are doing, you should always have charts, anatomy charts, besides you. When you get lost, go back to anatomy, then you'll find your way out. I think, did I answer the question? Okay. The clinical one. The clinical part of it, that also now underscores the APP, anatomy, pathophysiology, and physics. Nerve injury usually causes what? Numbness and the pain. Tendon injury will only have pain, which will be exacerbated by certain motions. If you have tendon injury here, doing some of these will cause issues. And clinically, some locations of the pain, like here you have radial nerve and the compartment 1, where if the nerve, the tendons and the one is injured, we call it the washerwoman's tendinopathy, because they keep doing this, washing, injuring this. So even the mechanism of injury can give you a clue. But if it is now like the ulnar nerve here, you will have this tingling. If it was the median nerve within here with there's so many tendons, the superficial and the deep ones, you will find that the numbness is only involving this area up to the thumb. The medial, the lateral half of the ring finger to the, so that is how you can do it clinically. Do you have any other question? How to differentiate between bursitis and knee effusion. Still, that takes us back to the APP, the anatomy. You should know the locations of the bursas. Now, for the case of the knee, effusion of the knee will go into the suprapatellar recess. But if you see any fluid collection in the skin anterior to the patella, that is a bursa. You see one infrapatella, that is a bursa, not a fusion. Even we have another one here for the pes serine, where it attaches medial to the tibial tubercle. When you see it there and the area will always be tender, you know it is that. And the fusion is usually asymptomatic. Only when it becomes great is when you find that you cannot bend the knee. But the other ones are always symptomatic, they are very painful. And the fusions, not. Most of the times. I've worked on people with the effusions, unless it is traumatic, hemoarthrosis, but this effusion which comes, they don't even know it is there. It becomes an incidental finding. Is that answer clear, or it needs more clarification? Do you have any other question? So I thank you for listening. If you don't have any other question, I think we conclude with that. I will, at the end, I will leave the textbooks, which one can read. There are many. Even today in the morning, I came across something of 480 pages just on shoulder joint. So thank you for listening.
Thank you so much. I think we can do better for the work that's now our facilitator, we are very happy. And as I said early in the morning, this one day or a few hours of this day that we are doing the MSK will not be enough to learn, but it will be more than enough to challenge us going back home, isn't it? That the radiographers who can do these things. As we already said, we've been over prescribing MRIs in this country, and more often not helping our patients, especially for MSK. So we are beginning to change that discussion from MRI to first line ultrasound use, isn't it? Yeah, so this after, I guess this afternoon, we are privileged to have our chief guest into this room. And he's one of the leadership in the county. Her name is Dr. Joy. She'll tell us. She's been a friend to societal radiography in Kenya for a while. Extremely very supportive. You know the work that our own Richard Admiral is doing in the county is not.
Welcome to RadMed, your 360 degrees radiology and healthcare partner. Shop for all your radiology needs, from X-ray machines to ultrasound machines. We have it all. At RadMed, we are dedicated to revolutionizing healthcare. We are experts in radiology and healthcare equipments, serving all areas in Kenya. Why should you choose RadMed? Firstly, we provide high quality and reliable modern technology hospital equipments. Secondly, we provide personalized support for every client. Thirdly, we have a proven track record in successful installations. Globe Care Hospital in Eastleigh, we delivered and installed an X-ray machine. Lydia Key Memorial Hospital, we delivered and installed an X-ray machine and a computed radiography machine. In Calvary Hill Hospital, we delivered and installed an X-ray machine with a CR. In Ziwa Hospital, we delivered and installed an X-ray machine with a complete CR. In Mwanzawetu Health Services, we delivered and installed a
Madam Joy, Director, Daktari, our facilitator is Mr. Mtesasira. That name is, I don't know whether Mtesasira, you know what it means in Kiswahili. It looks like unakuanga na hasira. You are very emotional. Very emotional. I thought so, but he's very, he's a very humble gentleman. So as I have just given you a brief, he comes from Uganda. He's an instructor, a lecturer at the Ernest Cook University, where you send Ademayon to study. So he's one of the lecturers to Ademayon, a radiographer by profession with a specialization into ultrasound and even super specialization now into MSK. So he's going to help us to change that attitude in our country. And as I have said, we chose Nakuru because we want to come up with champions of MSK from here. Nakuru is a sporting city, and we wanted to give back to the society as an organization and as professionals. So I know that we'll be hearing from Daktari, but I want to say that Ademayon and Neri, you know Neri, because you know me in a forum where Neri was. They are already students to Mtesasira, and they are now helping us. Those are now the master champions who will now make our champions, and we go forward like that. So our facilitator, this is Meet, our director. She's the host as we sit here, and we hope that even after this we will engage. I'm sure that you will have more forums through her to come back here and to do much more capacity building. Yes, so I want us to appreciate, all of us appreciate Madam Director as she plans to come and speak to us. Thank you. Come and change this. Daktari, we are online, so every radiographer in this country will be on TV actually. Yeah. So you can change this to Madam. Come and do it. Yeah, sure.
Through here. Oops. You have yes.
Thank you.
Thank you very much, Mr. President. Good afternoon.
Good afternoon.
How are you? Are you learning?
Yes.
Have you enjoyed your stay in Nakuru?
Yes.
So I'm Dr. Joy Mugambi, but I'm a proud alumni of KMTC. You have been told I'm an alumni. So tumetoka mbali na tunaenda mbali. I don't know where to start. One, I'm the county director, health admin and planning. I do all the planning documents for the county, manage the HR, programs that are coming in, and that's why we have met with this team. I'm also the president of the Family Physicians in Kenya. And I'm the Secretary General, Commonwealth Medical Association. And we are proud to work with Sork because the work you do has over the years been underappreciated, but it has grown. And your recognition is coming and it is growing, and we hope that you can continue doing what you're doing and fighting for your space, but you can't fight alone. In Africa, we say, if you want to go far, go with others, never alone. And you'll see when even we were designing the obstetric POCAS, we said we have to go together. Did that put you guys in a space that really was recognized? Yes. And so as we champion even the musculoskeletal from our colleague from Uganda, and karibu sana, najua Kiswahili amuongei, I can gossip you in Kiswahili, but I will not do that for now. Mine is to welcome you so much, and we truly appreciate you. Hope my staff is studying, and he is about to complete because the report card has to come back to me. So we truly appreciate all of you because growth has to happen and we have to adapt to the new changes that are coming in the world. And things changing. Are you still in dark rooms? No. Si tulitoka kwa giza, tukakuja kwa mwangaza. And with mwangaza, things are becoming smaller, they are becoming more technology-wise, and we don't want to be left behind. We want to be advancing as we go. Then there has come the primary healthcare reforms. In primary healthcare, when we were designing the primary healthcare strategic framework, for us, we didn't leave you alone as family physicians. We said we have to work with the whole team. And with that whole team, the radiographers are there because you're important. Hata tukienda kwa community, wacha tubebe portable x-ray, tubebe portable ultrasound, and that's where the trainings come to be very important. We are having the TB portable. How many are having that, the AI one? We proudly own one. Ademayo has been championing that, and we have really done a lot of screenings at the community level. People who would not come to the hospital, not because they don't want, but because you can imagine yule mtu wa quarry, aende quarry asubuhi, ili agonge, so that they can break their stones and ensure they meet the quantity required for them to sell for the day. They don't have a minute to come to the hospital. That Mama Fua, you have given her a job, isn't it? In your house to wash your clothes. She has to be there before you leave for work. What time? 6. And has to leave there when you come back, because Joy has kept you at work until around extended hours, 6. When will she come to see you for an imaging? So when we bring them to the community, it helps a lot, and I hope you're learning even how to use those portable gadgets so that we get to utilize them more. So my brief history, where I came from a small village in Meru. Let me start with that because I come from a small village in Meru where I grew up, went to school, group of schools, but went to one of our zonal high schools. I was a very busy teenager. And teenage, you know, iko na maneno yake. And I managed to get my C+ in high school and went to KMTC. My plan was to go and to be a chef at Utalii. I even had my admission, but my mother had bigger dreams for me, to go to KMTC, become a clinical officer, or become a doctor one day. And I ended up in Portrees. Many stories in Portrees. I was not willing to do this clinical medicine. My first year was a difficult one. But I had a tough principal. Anyone who knew Nasengo? Principal Nasengo. Was he not tough? Yes, but he taught us a lot, and he really ensured that we were back straight and sound. I did my clinical medicine. I actually saw, as much as I wanted to fail and go back to Italy, I will not make it to go. So the best thing was to work hard and graduate. I graduated happily from Portrees as one of the top students. I went to Kiambu, worked for years, then left Kiambu, went to do NGO work. NGOs had just come into the country. Don't worry, I'm sweet 16. Don't I look so? I'm sweet 16. So those ones who are doing mathematics, wachaneni, I'm 16 with some years of experience. So when I went back to the NGO world, they had just come into the country. I was working with Mary Stopes. I did 1 year, was very successful. I ate all my gratuity. Those who are on contract, mujuage gratuity ni ya maana. Lakini hiyo gratuity ya kwanza nilikula all of it in one go. It didn't last even 2 days. So that was not value. So the next 2 years I worked hard, and then we were done a USID at Mary Stopes. Everything was shut down overnight, and we had no jobs. But as people were being asked to come for their letters, like we saw with USID, and we used to go for our letters at the UK embassy, I sat down and told myself, I am not going back to work as a clinical officer. I left Kiambu and told them, mukiniona tena mutaniona kama daktari. And here I am now losing this job in NGO world, and there was no other NGO to go to that was paying well. So I left. As I was seated one morning and people were going to get their letters, sikuwa nimefikiwa, I saw an advert that was seeking clinical officers to join university in Tanzania. And I applied. I had tried applying in Nairobi, I had tried applying in Moi, and all of them declined my applications. They were not taking clinical officers those years. So I went to Tanzania. Good thing I was admitted, and they were upgrading their clinical officers into medicine. And it took me time. It's always a process. And when you're an adult learner, there is money. Good thing I didn't have children at that time. I even didn't have a husband, but I didn't get one in Tanzania. I think they didn't want my speeds. Finally, I came back, but I had to take also in between a 2-year break. The good thing, I had my clinical medicine qualifications, and this was able to get me to do locums when I come home and be able to work. Those 2 years, I got a job. I worked for the 2 years. I made money. I paid my school fees and went back to complete my last year of university. I came back as a valedictorian. Simunipigie makofi. And that tells you we are examined at a time when you're teenagers, at a time which is difficult. My dad was also going through a lot when we were doing our A-level, our Form 4. And he was going through a tumor. Cancer was new in this country. And it was a difficult time for me, being examined at Form 4 when you don't know if your father will live or if he'll die. Chemotherapy was new, it was on trial. And they would go to KNH and he comes back throwing up, and you're seeing your dad hair falling off. It was those bad times. And for me, as much as I would have wanted to do my best, I didn't make it. But I knew I had the brains to make it. So everyone has the potential. Just choose your pathway and pursue it. I came back, did my internship here in Nakuru, had very great mentors, who one of them told me, I'd applied for obstetrics, told me, no, you're very good in all departments. There is a new program that has come up in Moi, apply for family medicine. And I went as one of the first ladies to train in family medicine in Kenya. And here I am, enjoying what I do. And I hope this inspires any young person out there. It's never the end. Keep pursuing your learning goals. They can be small steps, big steps, and money should never be your limiting factor. When you look back at what you spent the whole of last year, if you had invested it in yourself, you'd be very far. I look at my gratuity from Maristops. It paid my 3 years school fees. My shares at Afya Sacco, which were there from when I was a clinical officer, they paid my school fees, they paid my upkeep, and they made sure that I got to where I'm going. So don't look at money as a hindrance. It should be your growth point. Whatever you make, go out. When an advert comes up of a training, take it. As much as I said I'm 16, I'm 50. My 20s were good and exploratory. My 30s were serious with a lot of studying and getting my children. I got them in my 30s. Mimi ni mama mzee. Those are the ones you call old premise. But my 40s have also been part of growth. But I wish I knew what I know now when I was in my 20s. I would not have missed out. As you go on, we are doing a lot of learning from our support here. Please use that information not only to learn, but also publish. How many of you have got publications other than ile mulifanya ya shule? I know the Aga Khan people, Prezo here, there. You see, I'm counting only like four. But you have beautiful case studies. Every day when you touch in that department of yours, you see things we have never seen in our lives. True or false? Where do you write these things? Why should a Mzungu come and take it and go and publish it when it is you who saw it first? Why are we being discovered in 2026? Why are you not discovering yourselves? So I challenge you, next AGM, I want to come and see case studies, see them displayed all over of images we have never seen ourselves, even as doctors, that we can really learn from, that you saw in your practices. Just photos that make us really speak to ourselves and really learn from each one of you, because you also have something for us to learn as doctors, inclusive of why not MRI and why ultrasound. So with that said, I challenge you, my radiographers, to take this head on, teach us what you know, and let's work together. This meeting is declared open.
Betty or Stella?
Yes.
So let's put your hands together for Madam. I believe that even if you don't learn anything today, even if you do not learn anything today, you at least will leave here for the interest of time, you will allow me to just introduce so that we remain doing our core objective. So, Madam Director, I was saying that it's fairly a young profession, radiography. Old, but in terms of growth academically in this country is now that we are waking up. We are really challenged by your experience, most of us, starting from humble backgrounds and forging ahead. Secondly, we are extremely very sensitive in terms of gender, regions as well. So we come from across the face of the country. In Europe and in US, radiography is majorly done by ladies. There are more ladies than men in UK, US. But in Africa, it is the other way around. And because of that, we've also been doing affirmative action to bring on board a lot of ladies into the practice. Of course, we know the reason has been the stereotyping of STEM among ladies. Somehow, Africans were meant to know that physics is only done by men. But that has changed ever since, so we have quite a number of ladies. So I want to introduce them quickly. She's Madam Catherine Nadema. She works at Kiambu County. She's actually the Admayon of Kiambu County. But in the council, she represents industrial radiographers. I know as a family physician, you know radiography cuts across human, industry, and animals. So she represents the industrial radiographers. It's an area that we want to work around to bring them on board for issues to do with safety. Because as it is, we are being screened all over this country. No one is concerned about the amount of radiation one gets passing through those screens every day. So it's a discussion we have. Number 2 is Charity Waitiki. She's an MRI CT specialist, radiographer at Mata Hospital. She's the radiographer council member representing veterinary radiography. Again, one common health, how do you call it? One health, so that the medical, human health and animal health is one and the same thing. So she's representing our colleagues who are working in the parks, trying to acquire images from our animals. She's not a veterinarian per se. It's an area we are developing. So we are working around how we can bring them on board and all that. Chocho which we met in, Kericho, representing county radiographers. Madam Nancy Chepkwon, she's one of your staffs here, but from KMTC side. She's the HOD of KMTC Radiography and Imaging Department, representing radiographers in the academia. Then the other one is Charity Ferista Cherotich. She works with Moi Teaching Referral Hospital. She's representing the medical radiographers. Also CT/MR radiographer. As we all know, radiography is quite very versatile. So we have areas of people you venture. Personally, I venture into ultrasound more. Then the gentleman in white is Mr. Sidney Jau. Was my classmate when we started, when we were also very young. He's the treasurer for the society. He's a money man, and he's a politician upcoming, and from Kirinyaga County. And he has worked in Nairobi Hospital, and also from the industry, General Electric, the one that supplies our equipment. Then Mudi Mayenga, you met, he works at Aga Khan, you met him, and is a council member representing radiographers in private sector, faith-based and private facilities. He works in Aga Khan, but currently is acting Secretary General for the society because the substantive officer is out of the country at the moment. Then the next is David Muli. David Muli is a council member representing National government radiographers at national level, level 6 team, and he works at the University of Nairobi radiology. They run a radiology department at the University of Nairobi for training. Yes, and I know a few others are not here with us, but we are a council of 11 from across the country. Yes. Thank you. So I think I don't know whether there is any reaction to Madam Director. Otherwise, I can give it back to maybe Mr. Sasira, you can say something to Madam Director. You can, anything you have, you may want to react. So, Madam Director, you can hear from our facilitator a word or two. Maybe there's something you may want to share.
Good afternoon once again. When she said her name, I thought she was Uganda.
Yeah.
So if you come over that side, you can leave. No one will even know you are not, apart from the Swahili, which will give you away. I am fascinated that it's really a discipline which many people disregard. When you talk about family medicine, now what is that? But they forget that in the developed countries, you don't have a GP. The general practitioner is the family medicine specialist. And
recently, one of my cousins migrated to Scotland, and the first requirement for him to settle was to get an assignment to a GP. So when he got a GP, he told me, now I'm done. I can settle and live here. Without a GP, you can't do anything. Wherever you go, they toss you back. And remember when I told you the stories about the physicians, a GP, general practitioner, sees someone, you refer them to the GP, to the physician. He writes 5 pages of history, and he says continue with the treatment. So now I wonder what they really do. So I'm very glad to meet you. And now I see you in another capacity as Ademeyone's boss. I am very happy to meet you. And I'm really fascinated by the story you gave. Even me, I share the same story almost. When I was doing HSC, I got the same marks in all the things at O level. So when I went for secondary school, I wanted to do PCM. I always saw myself as an engineer. When I reached the school I wanted, they told me, with these marks, you can't do PCM, you have to do PCBM. So I did PCB. And first semester, first trimester, first term, we didn't do any exams because I wondered even what we did. We studied for 3 weeks and the term ended, so we went for term X and came back for second term. And that's when we had the first exams in HSC. And I remember I found the old boys who had joined from S4. For them, they had a practice. The moment you finish S4, you start doing coaching on what you will study. So you reach a class and the teacher is cruising, and they are saying, yes, yes, yes. For you, as you finish, the man is rubbing off. I said, what am I going to do? So I said, no, I should catch up. Now it was my first time to be in a boarding school. People waking up for winter. They gave me some assignments for mathematics. I didn't do the work. The first lesson, the teacher said, okay, we shall bear with you. Next time you do the work. Second assignment I didn't do because I was interested in watching football. Those of you who know Uganda, I was studying at Shivuli SS. We are calling ourselves the football powerhouse. So after class, I would just watch football. No time for doing the assignments. And the man realized this man will never do an assignment. So he started saying, class, we have concluded the lesson. All of you do exercise A, B, C, D, and the miscellaneous. You know that book, Backhouse 1 and 2. So, and he would say, Mutesa Asira, do A, D, E, and the miscellaneous. And people are saying, why Mutesa Asira doing less? But I realized in the evening as we got to watch football, these people had done all the work. They just opened, they had 2 suitcases. They just opened and pulled. We did what? Miscellaneous equations. Assignment A, B, and they piled them ready to hand in the following day. And instead of watching soccer, I have to go and do the work. I said no. So I kept watching my football. When I saw things were getting tough, now that was with mechanics, a textbook which I don't think should be used for secondary schools. That mechanics is for university level. It was called Shorter Intermediate Mechanics by Humphrey. I said, today let me be serious for once. The first time I did winter was the last time I didn't winter. I had assignment 1. I did numbers 1 up to 6. I failed to do number 7. I did number 7 until I realized it was morning. But only when it was morning, I realized I could do 8. You could skip 7, do 8, and continue. I never went back for winter, the whole of HSC. And now when it came to 3rd term, I got financial trouble. I even paid the rest to tuition after graduating with my diploma. So financial challenges should not make you give up what you want to do. I continued, but that affected my grades. Because I remember the first exams we did, they read people who had performed the best, and I was among the best 4. So these old boys said, no, we have a problem. This man has serious issues. There is no one who has ever joined our exclusive club from outside. But now the financial things got me that way. And I anyway finished graduating, and it was hard for someone external who was not an old boy from S4 to continue from senior 5 direct to senior 6. And the headmaster was a famous man, used to say, try your talents elsewhere. He tells you either repeat S5 or you try your talents elsewhere. And the mathematics teacher told me, you don't do courseworks, you don't do what? If you pass my exam and you continue to S6, you will be a genius. So I said, a genius is small. I'm like more than 2 geniuses. And now the students named me Guinea. And I was very notorious to an extent that I went to the library 3 times, and they told me you can never come back to the library. So whenever I went to the library to get a book, the librarian would say, Mutesa Asira, come out, pick the book you want and go. For you know where you read from. You go to the German what? Language skills lab, you read from there. Don't stay in the library. I was giving them hard work. He found me reading entrepreneurship book and economics. And he said, which course are you doing? PCBM. Your section is there. What are you doing this side? I said, no, I read the other things. I got bored and I'm reading this. He said, just after 30 minutes. You man, you are just causing confusion. And I was always the first to pick newspapers. When it comes for the newspapers, I had to find page 1 from Ademayon, another one from there. And correctly said, there is a problem with you have attention disorder, you don't read with your colleagues. And one serious thing is I was prone to tonsillitis in HSC. One time I went to do a physics exam and I was really feeling bad. I drew diagrams without a ruler using a pen, and the man crossed and said, I gave you 0.5 because you put your name. And he said, now this is the time to embarrass this man. He told me, you are the one going to do the corrections. So when I went on the blackboard, I was doing everything, and they were saying, now, why were you fooling around in the exam? But anyway, I managed. I graduated, I passed the HS without any problems. And the man called, he said, you're a genius. The way you have been doing and you continue with S6 without repeating, it's impossible. Now I went for radiography. I didn't even know what it was. When we were filling forms for university that time, it was only Makerere, I think, where you would go. And now I knew I cannot do this. These people told me not to do the things I wanted. I would be an engineer. Anyway, they gave us other forms. They called you other tertiary information forms to fill. I filled the form, and there was physiotherapy, around so many courses, 16. And I said, but there is pharmacy and radiography. Let me choose radiography because the name sounds fancy, then pharmacy. And now I go, results come back. Makerere, no medicine, no pharmacy, no dental, but forestry. I said, forestry? Am I going to become a monkey to go to the forests? As I was contemplating, I went to the ministry to check, and I was shortlisted as #1 for radiography. I joined the school, and they were only admitting 10 students at that time. So I continued, finished radiography. Now somewhere in second year, like fun never ends, sometimes I would skip radiography schools and go and attend pharmacy things because I wanted the 4 quinolones and the 8 quinolones and the aminoglycosides. So I would attend the pharmacy lessons, not hours. So sometimes a teacher did roll call, and now the principal of the school asked me one time, now you man, which course are you doing? Is it radiography or pharmacy? I told him no. I had gone that side to pick aminoglycosides and benzodiazepines. I said, I need to talk to the head of your school. And actually, fun enough, when I think it was a problem, the ministry had admitted me twice. So the other teacher was not wrong. I was on the list of people doing dispensing and at the same time doing radiography. So, and he told me, you see how you killed one spot for another person. We thought we admitted the actual number we want, and one person missed because of you. I said, the problem is not mine, it was the ministry. So I finished radiography, and our cohort was the first to sit ultrasound as an exam. We had a lot of struggles. Ultrasound was new, and radiology were saying we are the ones who want to do ultrasound, the others should not do. But fun enough, the person who was teaching them ultrasound was a radiographer who dropped out in the 3rd year, Liverpool College of Ultrasound, because the teacher called him a monkey, and he had to slap the teacher. So he was disqualified, but he had learned many things. Then that's when Professor Koya came back from Thomas Jefferson, and he said, no, these people must do ultrasound, and we are starting with this cohort. So my transcript was the first one to have ultrasound as an exam, labeled as part of technique 2. But the previous people were only doing a plain X-ray and fluoroscopy and CT. From there, I worked, and at a certain point I said I must go back to school. I applied for medicine. The first time, I was not shortlisted. I applied again, I was not shortlisted. I applied the third time, this time using all the possible avenues, even sat an aptitude test. And I had a colleague working in the same place told me, why do you waste your time with that thing? I've sat it 3 times, I've never passed. But here is some reading material about it, you read and go and try. I passed the aptitude test and he told me, how did you make it? Usually when you pass it, it's valid for 2 years. That time they didn't set paper 2, which would let me into medicine. And the ignorance is bliss, I didn't care. And I didn't even know that the license is valid for 2 years. I went to the academic registrar and asked him arrogantly that what is so special with medicine that I apply 3 times and I am not admitted. He told me, my son, you know there is a lot of politics. Here we rank people by performance, then we admit. And now the remaining position is the son of the minister, son of professor, son of who a call from State House, and the places are done. So, but in the powers given to me as me, I can admit you for a Bachelor of Medical, for a Bachelor of Radiography. I told him that if you look at all my forms of application, I've only been applying for one thing, medicine. I won't do anything else. Now, 13 years elapsed. Now this time I said I'm going to school this year. I happened to work on one of the CEOs. Now is the current chairman of the Uganda Revenue Authority Board. He had come to do a medical examination. It was a Friday evening. I went to the mosque to pray, and the preacher talked about when you are presented with 2 options, as a human being, always choose the easier option. So I was weighing medicine, radiography, which one is easier? So when he came for medical examination, I worked on him and I told him, I have some challenge. There is a decision to make. I told him this year I want to go back to school, but I want to do either medicine or radiography. He asked me, what is your motivation to do medicine? I told him I want to do charity. He asked me, how many doctors do you know do charity? And I don't know any, that's why I want to be the first. And he told me what prevents them will also prevent you. I asked him, what is that? At that time, he was CEO of DFCU Bank. He said, when I analyze the data, we have information about medical people. And I think the doctors earn more in health than any person. By my standard, they are poor. That's why they don't do charity. Charity is a domain of the rich. He told me, if that is your motivation, you won't benefit from what you want to do. He told me, but where the world is going, 10 years from now, people are specializing, and every specialty will matter. It is easier for you to continue with your radiography, and you will not regret it. But now as I talk, in Uganda, you see the problems of interns. You have to finish and wait another year until you get internship, because the number of doctors being produced is bigger than what hospitals can offer. And it really hurts. A doctor works a duty of 8 to 8 for 100,000 Uganda shillings equivalent.
30,000 Kenya. 100,000 Uganda.
No, that is around just 3,000 Kenyan shillings for the whole day. You work a whole day 8 to 8 to earn 3,000 Kenyan shillings. And as you say, this money is it, I don't want the job. There is someone whose fuel tank is indicating ready, says, me, I can work for that. So you keep on the job. And that's how I joined actually. And I did that Bachelor of Diagnostic Ultrasound. But since I had taken years, the first class I entered was a pathology. And the man said, to show you the importance of pathology, choose a disease. I show you how it affects the body from cellular level to the organ, to the real human being as a whole. And we chose malaria. The man talked, and he said, the introduction is done. We meet tomorrow, and we continue. So now, hell broke loose. We started with meiosis and mitosis. And the man was talking about gap stages, gap stage 1, gap stage 2. I looked at the man, I said, I think I'm in the wrong place. Why did I come here? To make matters worse, next lesson was physics. And now the man also came and talked. He was a very young man. I said, but this one I'm even older than, and what is he talking? Things were not easy. It took me like 3 weeks for the brain to reset that now you were a student, and I started grasping things. But a lot of water had gone under the bridge. So I had to read twice to understand and to catch up. After that, I said immediately, I think, why do I waste time? Let me enroll for the masters. I enrolled, and masters is not an easy thing. Apart from education, there is also politics around it. Most people don't graduate because they get the politics wrong. Masters, I believe, is to inculcate a sense of maturity in someone, how to negotiate challenges. Because all lectures were physical, the ladies are lucky they can have some online. All lectures were physical. You could not work. You needed the money, and you have to study. So it was a big challenge, to one extent that one time, a colleague of mine in class told me, you know that we are the only 2 married people in this class. What are you doing here? Why did we even join this thing? It is becoming a big problem for us. You look how these single people are enjoying. I think we should get a way out. But he told me, we have already completed 1 year. How do we go out of it? The only way is to continue. So we did that, and finally we graduated. And I tell people that for masters, don't choose a hard research topic. You are not doing any self-actualization. You pick the easiest and you get to pass. If you want to do complex things, do them in your free time. Just earn your academic paper. I went and did the research which disturbed me. Like I told these people, I had to pause for 3 days, go back to anatomy read, go back. I spent around 11 million doing research as a student. And doctor, those are some of the things that are affecting the research here. It involves, because as you go to collect data, you are not earning. So if you create a fund at the level of the county to help people do the research, then you will see papers. But if that is not done, you will come for the next AGM and the status quo is still the same. The money is available. Richard has received. Richard has received. I am happy. He should. Mary should receive in Nairobi, not in Nakuru County.
I go work for the government.
You don't work for the government. For you are in trouble. Get a government job. Government job in Uganda, we say, is unbogable. During COVID, for us who were in private, salaries were cut to 30%. Traveling was hard. You cannot go to work. But the people of government, every end of month, they are calling, has our salary been deposited? You see them going to the ATM to withdraw, whether they have worked or not. So government is the place to be. Otherwise, private, you might end up doing nothing. Don't do the same mistakes we've done. It's government where you can work from start to end until you finish, but private, you can't. In private, you usually outlive your importance, and without you knowing. So, and Doctor, I was happy here. I met my colleagues in Kenya. All of them are titulars almost. So you have a very sober society. With that, I conclude my speech by saying that next year I will embark on the PhD.
Thank you so much, our facilitator. I think all those things is to make us feel motivated, isn't it? Yeah, that we can move. I think the point here from our director and from our facilitator is that keep moving, isn't it? Yes, keep making a step, keep forging forward. So I think we can stop it at that so that we press for lunch, I guess. So that when we come back, we are ready now to start our hands on.
Welcome to RadMed, your 360 degrees radiology and healthcare partner. Shop for all your radiology needs, from X-ray machines to ultrasound machines, we have it all. At RadMed, we are dedicated to revolutionising healthcare. We are experts in radiology and healthcare equipments, serving all areas in Kenya. Why should you choose RadMed? Firstly, we provide high quality and reliable modern technology hospital equipments. Secondly, we provide personalised support for every client. Thirdly, we have a proven track record in successful installations. Globe Care Hospital in Eastleigh, we delivered and installed an X-ray machine. Lydia Key Memorial Hospital, we delivered and installed an X-ray machine and a computed radiography machine. In Calvary Hill Hospital, we delivered and installed an X-ray machine with a CR. In Ziwa Hospital, we delivered and installed an X-ray machine with a complete CR. In Mwanzawetu Health Services, we delivered and installed a colour Doppler machine with 2 probes. Brooks and Cherith Hospital, we delivered and installed an X-ray machine with a CR. In Nanyuki Hospital, we delivered and installed an X-ray machine. Esobi Healthcare. Malkia Wings Hospital. Zenit Care Hospital. Nelly Nursing Home. Pro Care Cottage Hospital. Esther, a radiology entrepreneur. Itak Hospital. Peter, a radiology entrepreneur. Mugamo Medical Centre. Jabs Medical Centre. Why should you choose RadNet? Firstly, we provide high quality and reliable modern technology hospital equipments. Secondly, we provide personalised support for every client.